Welcome everybody. We're just going to wait a few minutes for everybody to join. I have the luxury of seeing as people do join, and it's going up rapidly, so not too long. But hello to everybody, wherever you are joining us from. We're very lucky tonight to have Dr Alyson McGregor and Lynn Enright with us. So, and I hope it's been a beautiful day for all of you. I'm down in Sussex and it's been absolutely gorgeous. Whereabouts are you, Lynn?
I am in North London, Northeast London. It has also been very, very gorgeous here. Yes, very humid, but lovely.
And Alyson, I think you're joining us from the States.
Yes, from the US. I am in Florida right now visiting my parents, but I'm normally headquartered at Rhode Island, so right outside of Boston.
How lovely. Yeah. Lucky you. So what's the weather like in Florida?
It is usually very sunny and humid. And so now with this time of year, there's that shower that happens once or twice a day, but then it goes away very quickly. So it's very nice to just warm up.
Great. And I'm interested, I'm intrigued because you both seem to have plants right there in view. I feel a bit left out. What why is that?
The Zoom background. It's a new thing. It's all we have at the moment to keep ourselves occupied, isn't it? Arranging our Zoom backgrounds.
Exactly. Just thinking about your frame is really it. So and I tip my hat to Trisha Reagan. She's a documentarian, and her documentary is Misdiagnosed, that I was a part of, and she taught me lots of these tips. So
well, I'm very impressed. I think that we will wait just a couple more seconds. And then I think we will begin if you're happy. I think we're nearly up to our sort of maximum number. So yes, I'm going to start. And really what I wanted to do was welcome everybody here today. And in particular to our two fabulous guests, Dr. Alyson McGregor and Lynn Enright. We are very pleased to have you both with us. Alyson is Associate Professor of Emergency Medicine at Brown University, co-founder and director of the Division of Sex and Gender in Emergency Medicine at the Brown Department of Emergency Medicine, co-founder of the Sex and Gender Women's Health Collaborative. On top of her academic work, she has been working shifts in her local emergency department during the COVID-19 pandemic, and of course has written this amazing book, which actually is a bit shocking too, Sex Matters. So welcome, Alyson. Lynn Enright, who is going to interview Alyson, is a journalist and author who's written on feminism, current affairs, women's health, and much more in newspapers, magazines, and radio. Her book, Vagina, A Re-Education, really should be a must-read book for girls at school. It just covers so much stuff about women's health, sexuality, all the things that are taboo. So we're delighted to have you both with us this evening. For those joining us, if you haven't already sent your questions, there is an opportunity still to do so on the Zoom Q&A section, so please feel free to do that. And before I hand over to both Lynn and Alyson, I just wanted to tell you a little bit about well-being of women. We ladies are 51% of the population. Yet it's pretty staggering, I think, that we're the only charity that funds across the breadth of women's reproductive health, and we fund research. So everything from trying to improve fertility, to stop premature birth, to find new treatments and diagnostic tests for cancer, through to things like menopause, and even for incontinence. Every day you will see our research in action. It's helping women like you, me, mothers, sisters, and aunts, etc. And you know, it's amazing that our work has given hope to those who've been diagnosed with a woman's cancer, to those who've suffered miscarriage and desperately want a family, and to the millions of women and girls who experience a health problem in their lifetime. So folic acid supplements, many of you will not know, started with our research. Ultrasound in pregnancy also started with our research, and actually it was Wellbeing of Women who funded a very brilliant, bright doctor many years ago, and he found the link between HPV and cervical cancer. And today we obviously have the HPV vaccine, which teenage girls take, and it's making cervical cancer preventable for the very first time in this country. And what's even more staggering is it's now available in 130 countries worldwide. So research is so important, and we're currently funding 33 projects. And to give you a very quick snapshot, we've got a centre in Liverpool developing personalised medicine to prevent premature birth. And then we've got research in Scotland, Liverpool, Birmingham, London, Southampton, all the key centres, all the key academic centres and big women's hospitals, looking at new treatments for ovarian and womb cancer, heavy bleeding, preventing strep B in babies, which has been in the news a lot, as well as unlocking the causes of miscarriage and stillbirth that prevent families going through this awful trauma. We're so proud of our researchers. Many of them have been saving lives back on the NHS front line, which means that some of our life-saving research is on hold. Coronavirus has also stopped almost all of our fundraising. With little income coming in, we are struggling to fund the research we so desperately need to. And what's important to remember is today's research is tomorrow's new treatment. We get no government or statutory funding, and apart from the job retention scheme, we will not be benefiting at all from any of the government funding that they've made available to just a very small number of charities. So please, if you haven't already done so, would you please donate today? There is a link in the chat section today. And to those who have, thank you. There are also links to Dr. McGregor's new book and also to Lynn's too, and those will go onto our website. We are recording today, everybody. I hope that's okay. And really, without further ado, I would like to now hand over to our wonderful speakers who really we're just so excited to have. And thank you very much. Over to you.
Great. Thank you so much. Thank you to Janet and Laura and Lena and the Wellbeing of Women for not only hosting this event, but for supporting an organization that funds medical research for women's health. And these types of initiatives are desperately needed to improve the health of women across the lifespan. And so also thank you to Lynn. I've just been so excited to meet you, and I've been reading your book and I've already sent it to some friends. And so I think it's just wonderful that we're together because you write about women's bodies are often overlooked by science as well. So it's a match made in heaven. I am going to share my screen. Okay. Does it look okay?
It looks good.
Okay. So, so I was asked to just give an overview of how I came to write this book, and my experiences and research working in the emergency department. So, okay, how do I move slides? Oh, okay, great. So I've always wanted to be a doctor. Really, I mean, for those of you that have known me, for my life, there was never a plan B. I always felt as though I was fulfilling some notion that I had to become this doctor. And the emergency department was just so exciting. It was, and it's community. It takes a lot of people to care for a lot of patients. And I really liked that sense of community. And so as I started finishing my training, I was wanting to become a clinical researcher. So I thought, okay, I'm going to split some of my time and do research. And it was a natural fit for me to think about women's health, because I grew up reading about the women's revolution in the 1960s and 70s. And I just admired those women. And I was so thankful for their work to improve our lives and understanding of our bodies. And so with that, I said, okay, let me choose a focus of research that will improve the lives of women. And as I started to look for projects and mentors, it became obvious that people thought I was referring to obstetrics and gynecology, that's that's the synonymous with women's health. And so I started to think about that because, as an emergency physician, I see women all day, every day, and mostly women actually, and they're in there with heart attacks and strokes, and they fall down and break their hip. And so I thought, are we saying that men and women are the same outside of their reproductive organs? Because that's not what I was witnessing. But our medical system has not recognized or accommodated for some of the differences that I've seen. Because the truth is that men and women are not the same in the face of health and disease. And we can see this every day. I see this. You experience it. 78% of all autoimmune diseases occur in women. Men are 30 times more likely to die of sudden cardiac death during exercise than women. Women have migraines and irritable bowel syndrome. 80% of the over 200,000 hip fractures in the US alone, never mind worldwide, are women. And so even when a disease occurs in both men or women, someone seems to have a greater incidence or a greater severity than the other. And why hasn't that been taken into account? And it really dates back to how human subject research first was born. And so we did a horrible job at this in the beginning. If you think World War II and concentration camps, there was no informed consent. You were experimented on, and that became our initial science. As things evolved, it became a little bit more less horrific, but without having lots of understanding of or oversight. So where this particularly became important was women joining studies in their reproductive age, because they was not known whether if they became pregnant during the study, if there was be harm to the fetus. And so examples like thalidomide, where women were taking it, their doctors were prescribing it, they were part of a study just to see how things were going. It was even over the counter in some places in the world. And the result was horrible birth defects. And so there was this backlash that was needed. It was the National Research Act that looked at, we need oversight, we need informed consent, we need institutional review boards to say that this is okay to do for humans. But what happened was they then labeled women as protected subjects. Because they just thought, well, we've had a couple bad experiences. Let's just have a paternalistic protection for women, and women were left out of the research pipeline. What was the result? Well, researchers thought this was actually very convenient because women have a variable menstrual cycle that happens monthly. And so in order to account for that appropriately in a study, you have to have lots of women in the study. Lots of women in follicular phase or their luteal phase or postmenopausal. That increases the cost. It makes it more complicated. And so women were just removed, and research was done on men and even male animals. There was this assumption that the outcomes based on men would be adequate proxies for outcomes in women. And so that's what happened. And if we are studying heart disease and stroke and cancer and infections and trauma in men, what's the one thing we can't study in men? We can't study having babies, and we can't study menstruation and breast health. So then we studied those things in women. But what happened is it trapped all the efforts into providing medical care for women into only those issues. Now, I'm sure if I were to ask the attendees on this webinar here, what is your greatest health concern? Or what do you think your greatest health concern is for women? I'm sure I would hear, and I hear this a lot, it's breast cancer, right? Because that's the consideration. You think about your reproductive bodies. Heart disease is the #1 killer for women. Lung cancer is the #1 cancer killer for women. So by trying to protect women, we actually did them a disservice. And this really is showcased with the example of the drug Ambien. So Ambien has been on the market for 20, 25 years. And guess who it's prescribed to? Women. Women are the ones who are more likely to have diagnosis of sleep disorders or sleep conditions or insomnia. So women have been taking this medication for 20, 25 years. And what happens is you can, after a drug is out in the market, there's something called post-market surveillance. So if you have a bad reaction, or if you discuss a reaction with your physician, you can go online and write a report that says, this happened to me. And what was happening was almost like 1,000 reports of women saying that when they woke up in the morning after taking this drug, they felt impaired. And then they would get into their car and they would have a car accident. And so the drug company wanted to make a new formulation of the drug and decided they should address that. And so they took the drug and they gave it to men and women. And then they stuck them in driving simulation studies after the amount of time it says you should wait to take the pill. So after 4 or 6 hours, they put them in the same studies that we use to determine blood alcohol levels in driving. And the women did horrible. They were impaired drivers. And so then they grabbed blood samples from men and women, and the women had 2 times the serum concentration of the drug than the men. They were given the same dose. So there was this realization that women metabolize this drug differently and should have their own personalized dose. However, that was after 20 years, and as an emergency physician, I see the results of motor vehicle crashes all the time. And we're not talking about a neck sprain or a backache. We're talking about life and death. And that simple sex-based dosing regimen is life-saving for women. And when you think about it, what else is out there that we should be looking at? How many other medications should we actually consider if there's specific case sex-based dosing? And what is that due to? Why are women metabolizing that differently? And if you think about it, this is where the sex matters comes in, the biological sex. We can remember back when we were in high school or in university, and we were taught that, there's a sex chromosome pair, and women get 2 copies of an X chromosome, and men get 1 copy of an X and 1 copy of a Y. And then that determines whether you get ovaries or testes. That's it, right? But the actual reality is that those chromosomes are in every cell in our body. They are in our heart, and they determine how we have heart disease. They are in our liver, and they are determining how we metabolize drugs. They're in our brain. They are dealing with our emotional ties to our physical health. This does matter, and it still is active in our system. Let's add hormones into the mix. Right? Something that we've just assumed was too difficult to study. Women having their cycles monthly and over a lifetime. Men have a variation over a lifetime too, but it's much, much slower. Hormones actually affect your blood flow to your brain. They affect metabolism of drugs. One example I like to give is that women who have a seizure disorder, it's been noted that a couple of the medications that women take to prevent having a seizure during certain phases of the menstrual cycle become less effective. So then they have the seizure around that time. And so what have we done in medicine? We've either told them don't drive, try not to, hurt yourself. Or we said, okay, well, let's increase the dose of your medication throughout, every day, the entire month, throughout the whole, cycle. So without realizing that we could individualize it. So then that woman is more susceptible now to the side effects of this higher dose of medication. It's this type of tailoring that we need to include into our thought process. And then we live in a gendered environment. Who created this environment? Right? The cultural role of gender. Women wear pocketbooks. How does that affect our posture and our health? The women in cultural areas that wear burqas and completely cover up. How does that affect their sun exposure and skin cancer and vitamin D levels? All of these things actually matter, and nowhere does it matter more when you think about crash test dummy. There does not exist today adult female size crash dummy, right? So car manufacturers design their cars to pass these safety tests. And so they are designing the cars to pass safety based on a male model. What's been the consequence of that? Well, we've been looking at this, and when a female is sitting in the front seat, either the driver or the passenger, she's 73% more likely to be seriously injured. She's 17% more likely to be killed. Why is that? Women have different pelvic girdles and geometry. They were designed to give birth. Women are shorter. They like to sit up closer to the dashboard. Men have thicker muscles around their neck, which is protective. These things are not designed in our world. So if you look at evidence-based medicine, what is our evidence based upon when 76% of cell-based researchers do not know the sex of the cell they're working on? They don't know if it contains XX or XY or how that affects the outcomes. 80% of animal-based models are still male. Clinical trials in humans, yes, more women are now being enrolled, but it's more complicated than that. We need to disaggregate the data by sex. So it's not just about sprinkling some women into a study and saying that it's fixed. Women make up over half the population, as Janet said. Women are the healthcare providers for their family. So if we think about this, how generalizable has this evidence been to women? And what has that done to our ability to detect disease? Right? So how has that, it's not just about medications. Think about how we recognize disease. So this is what a heart attack feels like for a man. It's a crushing sense of doom and chest pain, an elephant sitting on its chest, right? And that's what we've all been taught. But what does it feel like for a woman? I mean, it may feel like you kind of little discomfort, some nausea, some shortness of breath, dizziness. This is not recognized by women at home, so they're delaying thinking that this is a cardiac event. They're not recognizing it when they seek care. The nurse wasn't taught that women have heart attacks like this. The doctor wasn't taught. The tests that we use were designed for male pattern heart disease. And so this has been the consequence of why women have higher mortality rates. They're less likely to be treated for evidence-based medications when having a heart attack or stroke. So this is a system-wide problem. And I thought I would end with a patient example. So this is a patient that comes into the emergency department, and she is a young female, 40s, and she's been having some chest discomfort. It's not pain, but she was nauseous, and now she's at work, and her colleagues are saying, like, you should get checked out. So she says, okay, and she goes to the emergency department, and there's lights, and she's anxious that she's left all these deadlines, and so she's kind of worked up. And so the doctor says, you look anxious. And I see here in your chart that you have a history of anxiety. So let me give you some Valium or Ativan. Let's just, you probably feel better. So the patient gets the Valium and, Xanax and all that. It's like a big glass of wine. So she could care less about those deadlines at work anymore. But the chest discomfort's still there. That hasn't changed. And so the doc checks back and says, you know what, it's probably the reflux. You have the gastric acid, and I think you've seen a GI doctor before. Let me give you the Maalox and lidocaine mixture, and that should be it. Doc checks back, it's not any better. Well, when I press, it kind of hurts, so maybe it's musculoskeletal. Here's some ibuprofen. Nope. In fact, now she's starting to look pretty sick. She's sweating and not doing well. So the doctor says, all right, let me order some blood tests. In the meantime, here's some morphine, without realizing that actually women have greater side effects to opiates. And now she starts vomiting. So the nurse comes to the doctor and says, she's vomiting. Can I have some medication for vomiting? So they give her that. And then the doc says, well, maybe this is your heart. I mean, you're 40s. You're not supposed to have heart disease, but it could be. So let me just give you this nitroglycerin under your tongue. And if anyone has ever taken nitroglycerin, you realize the first thing you get is a whopping headache. So now she needs some Tylenol. I'm so sorry to say that this is not far from the truth, really. We don't understand our basic conditions of our medicine and our health and disease in women. So it just becomes we're just trial and error, trying to see what happens, because we are taught pattern recognition and women do not fit into that pattern. So what happens? Oh, maybe you're pregnant. Oh, it's your period, or it's your anxiety. It's all in your head. This is what we have embraced in our culture, that we're crazy. That this does not, this must be our fault. So in, my university, I run a division where we research the differences between men and women in emergent conditions through the emergency department. But we also educate lots of students and fellows and faculty, so that way that research can be part of the patient care experience. But what I found out was that advocacy is huge, and we all have a role in this. We can't wait for the research to come out, for be inserted into education. How can we all, have a similar revolution and take control of our own health today? And you can see that, this is starting to get out there. This was in the Netherlands. Healthcare based on the male body. Treat me like a lady, and look at those women. They're ready. They're ready to advocate for their health. And I know that we all can too. So the book Sex Matters is really about showing examples through patient cases of the real issue, and then empowering women to really advocate for themselves, and then hoping that will, help fix the solution while working within the system themselves. And so at that point, I will stop and be happy to have discussion.
Great, thank you so much. That presentation was enraging, terrifying, but also I think optimistic at the end, and I think we'll get to that, because I think we're going in the right direction. But certainly there's a lot to overcome, and you touched on it in the presentation, but you're very keen to make it clear that women's health doesn't necessarily mean boobs and tubes. I mean, i.e. breast cancer and gynae issues, although these are incredibly important areas. Why is it so important to you to make the case that women's health involves more than that?
Because when we think about women's health as the reproductive system, it silos all of the care into those areas. And then I look at outcomes of disease, and I see that, whoa, women have worse outcomes, higher mortality rates after having a heart attack. worse outcomes, higher mortality rates after having a stroke. Then we look at things like sepsis and infections, and women are less likely to be treated with medications that are out there. We have lots of protocols that women are less likely to go down that route. And so I think it's really important to look at women in a holistic way to try to improve those numbers.
Mm-hmm, mm-hmm. And I wonder, when it comes to women not receiving the right treatment, we saw in the presentation just how basic that is. Sometimes, the research hasn't been done, how drugs affect women's bodies and how drugs interact with one another in women's bodies. But how much of it is down to the biological sex and the lack of research, and how much of it is down to gender and perceptions of gender? And you touched on that a little bit, but I'd like to hear more about the she's very anxious or she's stressed, and how women get diagnosed with stress and anxiety more than men, and how that can complicate matters.
Yes, so if you look at most sex differences research has started with an observation. Why do women not receive this particular care? Why are that? And then you will look back and you say, okay, what's the framework we have here? The framework we have is those chromosomes and the biological sex and the genes that are turned on and off, or the hormones involvement. And so there's that. But then you look at the gender, and we live in a gendered environment. Society makes assumption about our genders based on how we look. And so with that comes some cultural roles. So men, if someone declares themselves a man in society, they're expected to do a lot of the labor. And, as an emergency physician or A&E is what's in the UK, I see finger injuries that go from the snowblower to the lawnmower. It's just, and we expect them to go up on the ladders and they fall down. And women are more likely to have the unpaid workforce. So that affects health as well. So when I look at the difference between sex and gender, I think it's really important to know the data individually so we can personalize it. So if we have a transgender person that comes in, then I can think, okay, what is that patient's biological sex? And then I think, okay, that's going to affect their cells, and what evidence I have based on that. And then what is their current gender identity? Because then I'm going to look at the literature of what it's like for women. Women want to have discussions with family and friends about treatment decisions. And so now I can individualize the data for each patient. Back to the anxiety issue, unfortunately, that has been something that has been an easy answer to, well, the tests that were designed to look for male pattern things aren't showing up with you. You're not fitting into any sort of pattern. What else are we supposed to do? So there tends to be an emotional fatigue based on the care provider who's like, this is the third time you've been in here this week. This must be your anxiety. Look, it says right here you have anxiety. And then the women are like, oh gosh, yes, it must be my anxiety. Now, anxiety is not, it can be a very serious thing, but most of the time, these women do not fit the appropriate diagnostic criteria for a generalized anxiety disorder. It just becomes something that is sort of forced on them because women feel culturally that it's okay to show emotion. And so people look at that emotion and see anxiety, especially in the healthcare system.
Wow, yes. I imagine that there's actually lots of medical professionals tuning into this discussion, and I wondered what you think they should do and can do to address this sex and gender bias in medicine. And what can they do, let's say, immediately in their workplaces, and what can they do in the long term?
Yeah, that's a great question, because when I do talk to health professionals, in the beginning they were thinking, oh, we'll just wait for the research to catch up. But we actually have a lot now that we can utilize today when we, every time we're seeing a patient. And what that is you look and you think, what is the biological sex and what is the gender identity of the patient? How does that affect their presentation? Because they develop diseases differently. And so what medication am I going to prescribe, and at what dose, and what side effects should I consider? And I think if you mentally start thinking of these things, that will decrease some of the bias that is so ingrained. Also, many of the physicians and healthcare providers are also researchers. And so making sure that when you design a study that you consider this. We are peer reviewers for lots of research. And so when we are reviewing someone else's paper, we should be thinking about that. If we're an editor of a journal, if we are sitting on an institutional review board, if you're on an education committee for healthcare providers, if you, you're on a curriculum committee, there are many of us in lots of these areas that have to do with health, either directly or indirectly, that can really have influence if you bring this up.
Mm-hmm. And then I wonder from the other side, and I'm looking at the questions that are coming in from the audience, and there is a common theme in a few of them, and it was a question that I wanted to ask. So it's, you just outlined there what medical professionals can do, and then what can we do when we go to the doctor and when we sort of suspect something is wrong, but don't know what, and how do we sort of make our case, let's say, in a way that will result in the best outcomes for us? I suppose what I'm asking is, how do we make doctors take our health more seriously?
It is the question. And so I think the first thing that we need to do is to take control over your own medical health record. So what does that mean? When you go to one hospital and they have their own electronic medical record, it's within a certain hospital system, and then you go to a different specialist and that's a different thing in your primary care. So what you want to do is make sure that you know your accurate medical record. What medications do you take? What reactions do you have? What are the doses? When were they changed? What tests have you had? Have you had an ultrasound and a CAT scan and all this stuff that I may not know that you've already had? This will just help the particular provider to move from there forward, instead of just reflexively, like, oh, let's just do that ultrasound. Well, you just had one. And so that's not going to create the answer. So I think really making sure that you have with you, take a photo of it with your camera phone, make sure that that is accurate. And then I really empower women and men to ask a lot of questions. So doctors went into this profession for great noble reasons, to help people. And so if you say, hey, that medication that you just wrote for me, is that the right dose for me as a woman? Is there anything I should know about this during my menstrual cycle? Will this affect my birth control? Are there side effects that I should be aware of at certain times? Hey, this test that you're ordering, is that specific to me with my biological sex? Or if you're transgender and you have those types of questions, be very, very open. Also be aware that that physician may not know the answer at that moment. But I think what you're doing is empowering them to look it up. And then that's going to be something that they'll have a discussion with you and be prepared to continue to do that. So those are the first couple things that I would say.
And I was interested actually, because in the book you mentioned, well, you can look it up, and there are online resources that can outline symptoms and conditions. And, I think that so many of us are sheepish about going to the doctor and saying, well, I think maybe it's this, or we've been told not to, Dr. Google, don't trust Dr. Google. But you actually say that, empowering yourselves both with the sort of the information about yourself, like you say, and having all of that up to date, but also having a look online is no bad thing.
Oh, I mean, it's inevitable. The access to information now is unavoidable, and I think it's a plus. because you can look up and have some information that you can then have a starting conversation with your physician. So I like to look at the physician as a very educated and experienced expert that you can talk with about your own health. So I think it's also very important that when you do look up those things, that you state your motives during your doctor visit. So if your motive is that you've had this belly pain for a few days and you looked online and you thought, God, it could be appendicitis, let me know. Then I can say, well, actually, appendicitis is on the right and not usually on the left. And then now I've gotten to the heart of your concerns. Or if your concern is, I have been, spent years just going from doctor to doctor, what can I do for you today? And if your motive is, just want to feel better for an hour, just a little bit, now I know how I can help you. Or I just want to feel heard. Or I just, want to know, my family member was just diagnosed with cancer. I'm afraid I have it too. These things really help get you what you need out of that visit. I also say bring an advocate if you can. Of course, COVID-19 has prevented a lot of family members and friends from coming, but they could still be on the phone. They could still be FaceTime, because I find that helpful too. If you are sick enough to go to the emergency department, you are probably not feeling well, clearly, and you're anxious about not feeling well. And when there's a family member there that says, she doesn't normally act like this, or, this is not, she does have anxiety, but it doesn't present like this. There's some sort of advocate that can really kind of put it in perspective. That's always helpful for us.
And you mentioned COVID, and Janet mentioned that you have been working during the coronavirus pandemic. And of course, we have seen, a sex difference in outcomes there. And that has been, quite a high profile incidence of that, in which men are suffering more and are going to the ICU more and unfortunately dying more. Do you think that sex difference will make people more aware of how conditions affect the genders and the sexes differently?
I certainly hope so. And I hope that continues to bring up the issue that studying sex differences is not a women's health issue. Mm-hmm. It is good science and will help benefit both men and women. One of the reasons why I spend so much time discussing its impact on women is because most of our medicine is male science, and so we have some catching up to do with women. But during a pandemic, it's really highlighting some of the fault lines that we have in our medical system, and looking at the fact that men are having higher mortality rates in certain areas really does highlight, well, why? And then let's think about it. Is it testosterone or the lack of estrogen? Is it the fact that lots of immune genes are on the X chromosome and women have double copies? That's why women tend to have more autoimmune conditions. Is it sociocultural behavior? There's been some discussions that men don't wash their hands as much as women. And it's most likely a combination. One of the other issues I've also been noticing is that in one of our states, in Massachusetts, the mortality rate in women is actually getting up there. And one of my colleagues in Canada is noticing the same trend. And so then I wonder, is that, the PPE, so the personal protective equipment? Women are, 75% of the healthcare workers are women. And guess what? That equipment wasn't designed for small faces. I know, I'm there, and I wear the standard male, but just the smallest version I can have, and they don't always have a lot of those around. So all of these things are really being highlighted, but I'm a lot of this is being rushed. Our treatments, our vaccines, we need these things done soon as possible, but I want to make sure that we don't forget to include both men and women and design these to determine what sex differences are really going to matter with COVID-19.
I want to come to the questions now from the audience, and there are actually so many. So I've been looking through them, trying to figure out the themes, and I think we have touched on some of them. But I suppose the big one and the big question that's there is, how can we expect to see a change to the current male-centric medicine until changes are mandated by government for both medical research and treatment? So I think that question touches on a lot. So basically, how and when will change happen, and where does change start? The individual can make a difference, but we need to kind of go to the bigger structures, I suppose.
Yes, and in the United States, we have been able to do that with our National Institutes of Health. So it's our government funding for research. And they have an Office of Research on Women's Health that began to look at, lots of reproductive health issues, but realized that women's health is, the biological sex hasn't been taken into account. So they have attached a requirement to funding that you include sex as a biological variable in your application. And so that at least makes some sort of standard that this needs to be done. And so I do feel as though the UK has not really embraced the term biological sex in their understanding of health and disease yet. And so that would be one of the main areas that I would say. Just like I mentioned about being on committees for education and medicine, we have women that are in government. And so what we want is Congress to mandate, the drug approval process. Because in the US, our Food and Drug Administration does not have the power to mandate that pharmaceutical companies include sex-based analysis. So they try to encourage them, but they just don't have that power to mandate them yet. And so that's another area that we could look at. There are lots of cogs in the wheel just to have our medical system run. And it was designed in a male-centric way, but there's so many pieces that we could work to change.
And I wonder about the individual coming to that research, and you encourage people to sign up for medical trials. How can people go about finding those, and how can people do that?
Yes, we need women to be enrolled in these clinical trials. And so, I think the first thing is local. So if you're involved in a trial, a lot of times you need to be, they need to have access to the research team. So I would look at your academic institution locally and see what is available. There are also many studies now that are global that are really just through questionnaires and through the internet. And so that's available to look at. It's important to realize that clinical studies look for healthy individuals, and then also look for individuals with specific conditions. And so if you have a specific condition, then look at the support groups. And a lot of times people are always talking about research studies through there. And then make sure you ask a lot of questions, because we want informed consent. And a lot of the hypotheses that have been based each new study uses the evidence from the previous study to move to the next step, and a lot of that has been based on men. And so I would ask the question, what is the data shown so far, and should I be concerned because I'm a woman, and how is that being protected? Look at the credentials of the research team, and a lot of this can be found online.
Brilliant. And I'm going to come back to one more question, and the questioner has said long one, sorry, so it is a little bit long and it involves a lot, but she says, what do you think has happened in the past 50 or so years? It seemed that there was a big movement of women that began to take control of their health needs, which coincided with the availability of contraception, the legalization of abortion in the UK and the US, and rising awareness of reproductive health. However, on the other hand, it seems that progress hasn't been made as quickly as envisaged. And sometimes it seems we haven't made much progress at all.
I know that is, that deserves a sigh. It really does. And I understand. I agree, and I wonder that too. Lynn, you and I mentioned, in one of our recent conversations, the fact that one of the reasons why you wrote your book, The Vagina, a Re-Education, is, because what happened with the women's movement is we made change, and then it fizzles away, and then people just become complacent in how the world is being run, and you forget that you think it's just been taken care of, And so with the Me Too movement, I really felt like this is it, because we're sort of energized again, and our awareness, our lens is really sharp, and that's why you wanted to bring up how we still need to take control over our own reproductive organs, never mind our entire body. And so I think it's important to band together, to use the energy of the masses to really push again to make this not go away.
Yeah, I think so. I think that so often when I was writing my book, I came across studies or facts that were new to me as a 35-year-old woman, but that had been around, and sort of been discovered and then rediscovered and rediscovered and rediscovered. And it's like, well, why do we have to keep forgetting everything only to rediscover it, And I
Exactly.
think, like you say, a critical mass and a sort of and not letting anything be a trend. So, not letting Me Too become a trend, not letting these waves of feminism come and go, kind of keeping going. There's one point that somebody in the audience has made, and I know it's something that you believe in and talk about, but so she has said, health is based on males, yes, but also white males. And I think you've said that before, that it's not only men, but it's a certain type of man.
It's a healthy white male, and so yes, that is not that is not generalizable to most of the population. And so I think we wanted things to be really simple in the beginning when we were first developing evidence and data. I just think it's time to get complicated. We can do it.
Yes, and that also impacts then, because there's another comment, and it says, I've seen brown and black women being overlooked before other patients. So, and that's something that you speak about in the book as well, that there's a sex bias, a gender bias, and a race bias, and sometimes those things come together.
Yes, it's compounding biases for sure.
Mm-hmm.
And I think it really relates to the fact that the structure was male, and then women were considered a subgroup, and race was considered a subgroup, and age and socioeconomic class, and this male was like where, and I say that, okay, well, women aren't a subgroup. We are two unique individual humans with our own DNA that's separate. So let's start with men and women, and then the subgroups of women. We need to look at race and ethnicity and culture and their gender identity, and figure out how that affects. I think once we change the way that we look at it, then we can really sort of elevate all aspects that have some sort of effect.
Brilliant. Okay. Well, I think, I feel like we all need to go away from this chat and think about how we talk to our doctor, and how we can help, whether that is, lots of people watching this are people who can start doing that immediately in their jobs, if they work in hospitals or in GP surgeries. And all of us, as a journalist, I can start to help almost, and then as patients, or as potential participants in clinical trials. So I think that you've given us a lot to think about, and a lot to do. And I think anybody who buys the book will feel like that at the end. You go through I think what you go through watching a presentation, but horror, anger, but ultimately, you know, a real desire to make that change however you can. So thank you so much for writing the book, and thank you so much for speaking to us. I'm going to hand back to Janet now.
Thank you. A big thank you, Alison, for that. It is illuminating. There was one question I just would like to sort of highlight. It was a lady who mentioned endometriosis, and she wanted to know why there was so little research into the area. We agree with you 100%. We are actually the only charity, and it's a charity who are funding research into endometriosis. I'm pleased to say that research we funded has led to the brilliant team, so led by a professor up in Edinburgh, and they think they have found a breakthrough. They're doing clinical trials at the moment. If so, it will be the first non-hormonal treatment for women with endometriosis for 40 years. I mean, that's the staggering thing. That leads me on to say we're activists and we do need to band together. We've really got to support ourselves and we've got to get the message out there. So everybody who's on tonight, please do so. Please support our work because, as I say, we are one of the very few funders. I mean, just something that sounds a bit silly but isn't is Botox. We did some research into Botox and using it for certain types of incontinence. So there are so many different things that need to be done, but without people like Dr. Alyson McGregor, we wouldn't be able to shine a spotlight on them. And I'm so really very grateful that you've written the book, that you were able to join us tonight, and that we had the brilliant Lynn Enright, who was asking the questions, who herself has also written a terrific book. As I say, all the details you can find in the chat section or on our website. If you haven't donated, please do, because you are actually helping all of us by letting us fund more research. And with 34 projects, we certainly need all the help we can get. Thank you all for joining. And it just remains for me to say, have a brilliant evening, rest of evening. Stay safe, stay well. And finally, thank you, ladies. Good night.
Thank you so much. Thank you for having me. And thank you to Lynn for helping me clarify a lot of the message. So this was a pure joy.
Thank you. Thank you, Lynn. Good night.
Bye.
Okay, bye.